Hello everyone. Today my lecture is on pre-prosthetic surgery. Prosthetics is the replacement of the missing teeth and contiguous oral and maxillofacial tissues with artificial substitute. Now these remains a significant number of patients who can never be made to use dentures effectively because of bone atrophy, soft tissue hypertrophy, or localized soft and hard tissue problems. In these patients, pre-prosthetic surgery offers significant contribution by removing hindrance for prosthesis stability and retention. It is always hoped that the results of the pre-prosthetic surgery is acceptable, both surgically and prosthetically. The services of an oral and maxillofacial surgeon may be required, especially as the surgical preparation becomes more complicated in these mm, instances. A team approach is needed with the surgeon and the prosthodontist serving as equal members of the team. Pre-prosthetic surgery is carried out to reform or resign the soft tissue and hard tissues by eliminating biological hindrances to the receive the comfortable and stable prosthesis. Pre-prosthetic surgery is defined as the surgical procedures designed to facilitate the fabrication of the prosthesis or to improve the prognosis of the prosthodontic care. Aim of pre-prosthetic surgery are: it provides adequate bony tissue support for the replacement of the complete dentures, provide the adequate soft tissue support, optimal vestibular depth, elimination of the pre-existing bone deformities such as tori, prominent myelohydrige, and genotypical, etc. It correction of the maxillary and mandibular ridge relationship, eliminates the pre-existing soft tissue deformities such as uterus fissuratum, flabbry bridges, hyperplastic tissues, etc. It maintains the functions of the ridge and aesthetics also. Characteristic of ideal dental base should be adequate bony support, soft tissue coverage, no undercuts or protuberance should be present on the ridge, no sharp ridges, adequate sulcus depth should be present, absence of peripheral scar bands, no muscle fibers to the which can mobilize the processes, no soft tissue pores or hypertrophies may be present, no neoplastic lesions on the ridge, proper maxillomandibular arch relationship should be maintained, and adequate palatal vault. Patient evaluation and treatment planning. Pre-prosthetic surgical treatment must begin with the proper case history and physical examination. A special attention should be given to the systemic diseases that may be responsible for severe degree of bone resorption. Aesthetic and functional goals of the patient must be assessed carefully. Long-term maintenance of the underlying tissues as well as the pre-prosthetic prosthodontic appliances should be kept in mind. Pre-processed surgical procedures can be classified as basic procedures which can be carried under the local anesthesia on a care basis. Advanced surgical procedures may require hospitalization and general anesthesia. Procedures which are carried under the pre-prosthetic surgery are ridge correction procedures, ridge extension procedures, and ridge augmentation procedures. Ridge correction procedures included the bone and soft tissue surgeries, which hindrance into the prosthetic appliances fabrication. Bone surgeries include the alveolectomy, alveoplasty, elimination of the unfavorable undercuts such as reduction of genial tubercles and myelohydrige, reduction, excision of the tori, maxillary tuberosity reduction, and exostosis removal. Soft tissue surgeries included the removal of the crystal soft tissue, which is abandoned, frenectomy, excision of the uterus fistulatum, and excision of the palatal papillary hyperplasia. Bony surgeries such as alveolectomy. It is the surgical removal or the trimming of the alveolar process is termed as alveolectomy. In the figure, the alveolectomy is shown, which is done with the help of bone plunger and file. Alveoloplasty, whereas it is defined as a surgical recontouring of the alveolar process, is not the removal of the alveolar bone. It may be simple alveoloplasty, interseptal alveoloplasty, or post-extraction alveoloplasty. Recontouring may be done. Reduction of genotypicals is also comes under the ridge correction procedures. Reduction of myelohydrige figures are shown. Excision of the tori such as palatal tori, excision of the tori such as mandibular tori, maxillary tuberosity reduction and exostosis removal comes under the ridge extension procedure, ridge correction procedures. Soft tissue surgeries included the crustal soft tissue is removed, which provide hindrance in the denture placement. Frenectomy, yani removal of the frenum, which interferes with the denture placement. Labial frenectomy, it may be labial frenectomy. Or lingual frenectomy. Extrusion of the Euclid's pituitarium. These are benign pedunculated lesions present as the excessive or tissue in the vestibule, frequently associated with the overextended denture border. These lesions are removed by sharp excision, cauterization, cryosurgery, or laser excision. Excision of the palatal papillary hyperplasia. This happens because of the chronic ill-fitting denture. Um, It is can be superimposed over by the candida infection. Denture should be relieved in this region and antifungal agent should be applied. Supraperiosteal excision with the extracautery should be done. Alveolar ridge extension procedure. Previously, I have told about the ridge correction procedures. Now they are the ridge extension procedure. Whenever there is an inadequate vestibular depth present due to mandibular atrophy or high muscle or soft tissue attachment, so to increase the retention and stability of the denture, deepening of the vestibule is considered. Sufficient amount of the bone should be present for the alveolar ridge extension or vestibuloplasty procedure. This can be done in both jaws, such as labial vestibuloplasty. For mandibular ridge, various procedures are recommended. Skajangian, Godwin's, Clark's, of diseases, and maxillary ridge procedure, maxillary pocket in the vestibuloplasty. Lingual vestibuloplasty may two types of techniques introduced: Torner's techniques and Cardwell-Beck's technique. Here, mental nerve transposition can be done to avoid irritation to the mental nerve. Alveolar ridge augmentation procedures. This procedures is done when the alveolar bone has been completely disappeared to the point where the maxilla is flat, surface is present between the vestibule and the palate, and in mandibular mental nerve positioned almost is at the crest. Here, alveolar bone height is less than 15 mm. So, vestibuloplasty is out of consideration in this case until the replacement of the necessary supportive bone is done. So, we have two options available with us: augmentation of the alveolar bone and place the implant. Aims: restoration of optimum ridge height with ridge form, vestibular depth, and optimal denture bearing area. To protect the neurovascular bundle, to establish the proper interarch relationship, improvement of the retention and stability of the denture, and improve the patient comfort for wearing of the denture. Material used for its augmentation are autogenous bone grafts such as iliac bone graft or rib grafts, allogenic bone grafts such as freeze-dried Gadwa bone, alloplastic materials such as hydroxyapatite, metal mesh with autogenous cancellous bone, or metal mesh with hydroxyapatite. This augmentation procedure, it includes the superior border augmentation can be done or inferior border augmentation can be done, interpositional or sandwich bone grafts, only grafting, visor osteotomy, and modified visor osteotomy. Conclusion: accurate diagnosis of the problem areas during the denture construction and determination of the necessities of the surgery is accomplished by careful evaluation of the informed systematically obtained from the patient, and as conservation is the philosophy of the surgical patient management, therefore every attempt should be made to preserve as such as oral structures as possible. Proper knowledge of the available and surgical procedures helps in achieving the best results. Thank you.